Welcome to Breakfast with the Chief this morning. What can I say about Stephen Lewis except go to page 10 of the Healthcare Quarterly you have, go to our website and meet our best read author by far. And he has no big head because of it. And I read Healthcare Quarterly occasionally, in this case on the airplane, and I found out that Ida is joining an organization called LifeLabs, but it's part of Borealis. Borealis is a very Canadian company, a very entrepreneurial company, so it's good to see that she's in the fold and she's really got an opportunity to shine. It's a wonderful shop, I can tell you. The people are great, Ida, but you probably have found that out already. So I'm done with that. That's it. It is now Stephen Lewis and Ida Goodrow's show.
Thank you. So welcome, everybody. As you know, this is sort of billed as Ida's exit interview, but it's not really. And for the next 40 minutes or so, I'm going to be asking Ida some questions about her experiences at Vancouver Coastal. We'll talk a little bit about her current transition. And before we get to the exit point, I'm going to go back to begin to the entry point, which is, Ida, I read your bio, and I saw a lot of pulp and paper in it. And then all of a sudden, there's this transition to be the CEO of Vancouver Coastal Health. What prompted you to embark on this journey, and what did you hope to bring to Vancouver Coastal that was informed by your previous life in the private sector?
Well, that's a good question, and Keith Purchase, who was the chair of Vancouver Coastal at the time, took advantage of the fact that I was living in Norway, had very little access to the Vancouver newspapers, and so came in probably with, what's the word, not having paid a lot of attention to the consumer beware part of the decision process. I think going back, Stephen, you may recall, and certainly most people in the audience would, that when I came, the health authorities had just been formed. In Vancouver, there were 18 or more agencies and boards, all with their own systems, their own structures, their own people, and it was to put it all together. So I think the board at the time was looking for someone with some management experience who could help support all the people who had really great clinical expertise to try and pull it all together, develop a strategy, develop systems, sort out how to deal with some significant budget pressures. So that's how we got there.
And when you got there, obviously you, like everybody else, knew something about healthcare, and obviously knew quite a bit about management and human resources and so forth. But it's probably the world's most complicated system. When you arrived and you were sitting in your office late at night after 2 or 3 months, did it ever occur to you that, good God, what have I done?
That's possible. I don't have a lot of recollection of that because generally the days were so full that by the time I was sitting in my office at night, it was, here's the stack of emails to go through. I mean, healthcare is very complex. The huge reward for people coming in from the outside is, in fact, yes, it's very complex, but the work is so interesting, has so much meaning. The people that are working in healthcare really see their jobs not as jobs, but as vocations. And so there's a real strong, immediately that you come in, you have a strong sense of here's the need, and here are resources, and then how can we pull all of that together to make it work? So very, very quickly I found, and certainly I know board members have felt the same, and at Vancouver Coastal, other people have come in from the outside, from the private sector. And I think generally within a very short period of time, if you're going to stay, you get caught up in the challenge of needs and demand and how to actually be able to meet that. That's probably the thing that if you sat up at night and went, oh my God, what are we going to do? Or what am I going to do? It's how to bridge that gap between here's the need and here's our ability to actually meet the need.
And tell me a little bit about your perceptions of the culture. Obviously, the private sector has a culture that is driven by the market. It's competitive. Bottom line is bottom line. It's cleaner in a sense. You find stuff, you make stuff, you sell stuff. You thrive or you don't. Healthcare as you pointed out, is quite different. It sees itself as a caring, needs-based culture, but some of the same issues apply. It's huge money. It's a big part of the GDP. It's a bigger part of the provincial government, so there is a financial discipline that we're trying to instill in it. What's the best thing about healthcare culture, and what do you find most troublesome about the healthcare culture?
Well, I think that certainly the best thing about the healthcare culture is the sense of commitment to meeting people's needs. And in the private sector, you spend a lot of time trying to make sure that people are motivated, that they feel committed to the work. In healthcare, you don't spend much time on that. People come in and they already have the commitment to meeting patient needs. So that I think is a huge positive about healthcare. The interesting thing, though, for me coming in from the outside was, even though there's this huge commitment to patient care, when you're in the private sector, you spend much more time actually thinking about customer needs, if you will. So if we can use the word patient instead of customer, there's actually less knowledge or focus on what does the patient want. There's a lot of focus on this is what we think the patient needs, but not as much focus on what does the patient want. And so that was one of the big differences. The huge challenge coming from the private sector is you learn how to work in a system where the objectives are really clear. So it might be profit, it might be a sales volume, it might be market share, might be efficiency. In the healthcare sector, the objectives are all over the place. The desire to balance a budget is huge, but at the same time, the desire to meet wait lists is huge, and the desire of someone working in an acute sector is to make sure that certain surgeries get done or MRIs are performed in the community, is to have more home support. And you say, well, what are we going to do? Are we going to meet all the access and efficiency targets? Can you do both within the budget? So sometimes people feel we actually are doing a better job on access and doing more for people, but the budget is impacted negatively. So what should be a good thing, given that the healthcare system is about meeting and improving people's health requirements and improving health outcomes. So sometimes people are doing that, but they're getting nailed because the budget implications are negative. So my experience coming from the private sector was it's not very clear. And if you're going to bring private sector techniques that are based on real clarity, some of them apply, but some of them aren't particularly helpful.
You raised the issue of meeting people's certainly visible needs. As you know, with the health accords and most government directives, they still tend to be pretty downstream. That the hot buttons are downstream. It's hip and knee procedures, it's elective surgical waiting lists and so on. And while we've got the population health vocabulary and everybody is intellectually committed to prevention, the ratio hasn't changed much, upstream, downstream. Do you think that it's impossible to shift emphasis in the system given the tyranny of the urgent? And how did you cope with that as a CEO?
Well, it was probably, for me, the single greatest opportunity and the single greatest challenge, because you're absolutely right. We all know that putting more effort into prevention, putting more effort into community-based care, helping support people to stay well and to stay home is, in fact, the very best way to not only have better health, but also to, in the long term, have greater efficiency. The day-to-day, though, is if you have a wait list in your ER, that's what has to be dealt with. And we did a lot of work at Vancouver Coastal to try and look at the continuum of care concept to say, well, here's where we should invest. But I have to say that at the end, after 6 years, the ratio of dollars going into the acute side versus community-based care had actually worsened rather than improved, if you were going to talk about that. So. Is it impossible? I don't think it's necessarily impossible. I think what may start to shift it is as people, particularly the baby boomers, age, and find that even though they have many chronic diseases, they can still live fairly independently, they're going to start to demand much more in the way of community and home-based care. They're going to say, I don't want to be in the hospital every 2 months because I have 3 different medications, and then I got the flu and they gave me still another medication, and then that threw off all my other treatments, so now I'm in the ER because the appropriate community care wasn't there, or whatever, or I've had wonderful hip surgery or knee surgery, but the physio isn't available, so I'm not actually improving. So it may be that demand from people who are trying to live independently may help shift that. It's a struggle, no question.
And do you think there's a parallel here if we look at the broader economy? I mean, not to oversimplify, but you could say, look at North American automakers. They had a very steep discount rate for building a car that was actually energy efficient, moving to electric cars, the famous delaying the Chevy Volt kind of thing. We're all fixated by short-term thinking. Healthcare is no different, and the short-term thinking is promoted by the real suffering. If you've got a hip that needs replaced, you're in pain. So should we alter our rhetoric a little bit? Should we, if you were going at this structurally, would you say it's a good idea to have a region responsible for the whole continuum? Or would you say, no, you've got to sequester the upstream stuff? You might even take it out of a region or take it out of healthcare in order to get that emphasis done. Because, as you said, I think you're right. I think Vancouver Coastal could fairly be said to have done as much or more in community engagement, population health, as any region in the country, and yet, as you say, the ratio got worse, not better. So what would you do if you were the redesigning this?
Well, I think there'd be 2 pieces. One is within a region, I think if you were able to have more influence over what the services that are provided in the community and primary care, and I think you could make more trade-offs. You could certainly take more out of the hospital, move it into ambulatory, move it into the community. So that would, my belief is that would help, however that could be done. I think the other, though, is, as you said, is will some of that demand or push come from just people who are outside of the healthcare sector, so whether that's private care or could be volunteer, could be family, could be individuals. But I think the need that people are going to have for health type of services, many of which would be outside the traditional definition of the Canada Health Act, is just going to keep increasing. People are going to want that. They're going to be focused on comfort and independence and functionality. And if the healthcare system can't provide it, then I think we're going to see people finding other ways. And it may be as a private pay, but for people who don't have the means, I think in the longer term, and this would be perhaps optimistic and a bit utopian, but it will be communities stepping up to support people who are aging, don't have the best health. That could be peer support, where you already see in some cases, addictions field, for example, where peers, in fact, do make a huge difference in terms of health outcomes. But I think healthcare is going to become a more community-oriented, and I say that in the broadest sense of community, because otherwise it's going to be impossible for people to get the care they need.
Let's turn to my favorite topic, which is the organization of physician services in a health region. So let's go back to your pulp and paper days, and say you're the CEO of a pulp and paper company. They're your employees. The employees essentially do what the company plan is. And then they said, no, we're going to reorganize this side. You're the CEO of the company, but all the employees get to have a separate relationship with the customers, and they're going to spend your money however they see fit to meet their needs. And whatever transaction that takes place between them, you're going to pay for. But would that work for you in pulp and paper?
I think in pulp and paper, that would not be seen as a good thing necessarily. Yeah.
And so this is clearly an incredible challenge as an executive in healthcare, right? That you have these quasi-contractual, some it's closer in the institutions, but basically, at best, it's quasi-contractual. And in terms of healthcare being the sum of a zillion transactions, you don't have a whole lot to say about those transactions. And they're not, in Canada, terribly rigorously evaluated. And when we do find big variations in practice, they're not actually addressed very much. So how do you cope in that environment? What is the strategy for dealing with that, and do you think it's sustainable?
Well, I think it's fairly clear right now. The strategy is to try and bring physicians into decision-making process to the extent that you can, to get some self-regulation isn't quite the right word, but to have the profession also focus on what are the most appropriate protocols, evidence-based, and so forth. Is it sustainable? I don't believe it's sustainable in the current form. My, again, hope would be that physicians demonstrate more leadership in the area of how we're using our healthcare services. So whether that's appropriateness or evidence-based care, or adherence to protocols, or just simple adherence to quality. We've created a system that, since we're using the pulp and paper example, would not work in the private sector. It's a little bit like Microsoft saying, we're going to create a great company, but everyone who is expert in software development is going to be over there, and we're not actually going to involve them in any of the decisions that are made in terms of how this organization is going to develop. So we've created a system where, and it may be the choice of physicians, but it's also been the choice of administrators and ministries to have physicians over there and decision makers, whether they're the bureaucrats or the administrators, over here. And to me, that's the piece that's not sustainable. So is it just about making sure that physicians, quote unquote, toe a line? I don't think so. I think it's about physicians being much more involved in both the good and the bad, the hard and the attractive, about being part of a system. And that means taking accountability not just for the particular piece of work that physician may be engaged in, a specialist or whatever, but it's taking some responsibility for the whole system. And the big system problem is, here are the demands, here's the resource that taxpayers are willing to provide, and guess what? There is a big gap, and what are we going to do about it?
That goes right to the heart of two cultural problems. One is clinical autonomy, which is highly valued by all professions, but particularly medicine, which really has the most discretion in healthcare. And the other is, as you suggest, accountability. If I can avoid accountability in my life, I do it at every opportunity. And so this is hardly a criticism of a professional who wants to do the same thing. How do you change that culture, and where does it begin? I mean, when you get them new out of med school and through their residencies, strikes me they're already pretty well socialized into a fairly conventional view of the world. At what point would you, again waving a magic wand, where would you start to turn that around?
Well, I think you're making exactly the right point. You start in the educational, in the academic institutions where people are being trained. I mean, to a certain extent, you're right. People don't necessarily want accountability if it feels like it's going to be onerous and difficult. On the other hand, most people don't like having decisions imposed on them. They don't like having things done to them. So that's the quid pro quo. You may not want the accountability if it's grim or ugly, but you also don't want somebody else who may know less than you do, or or you think they know less than you do, making decisions that are going to have a huge impact on your day-to-day work. So the appeal of having more accountability and more leadership is the ability to influence what actually gets done and the decisions that are made and the resources that are allocated.
Let's turn a bit to the other big job that a CEO does, and of course your own background includes stints as Health Human Resource VPs. We have a massive number of people in healthcare. We have, I don't think anyone can count the number of occupations anymore, but upwards of 40. Credentials are rising. Theories are proliferating on what health and healthcare is. We talk about teams, but there are lots of trajectories in the opposite direction. And I think one could argue that many, many people in healthcare are working at the lower end of their capabilities. We see from the UK, for instance, in their Releasing Time to Care initiative, that they've actually increased the proportion of time nurses spend at the bedside by 20 to 60%, just by doing some fairly obvious efficiency improvements and delegation. Do you think we've got the HHR thing figured out? Do you think that ramping up enrollments, as we have done, is the key to this, or do we need to reinvent the HHR model in healthcare?
Well, I've certainly been vocal during the years that I've been in the healthcare system. I think the health human resource side is where we're probably weakest in the entire system, because we don't focus as much as we should on what is the work that's getting done. I think that's exactly to your point. So if these are the needs of a patient and this is the work, then how do we organize the experts or the practitioners and the caregivers around that work? And if you do that, then exactly as you say, you try and match the level of difficulty of work or the expertise that's required with the professional training of the staff. We often do it in the opposite way, and we do end up then with systems where nurses may spend half their time doing administrative and clerical work or even housekeeping or whatever. That clearly doesn't need to be done. I think what's encouraging is there is work going on now using process redesign and other different techniques to try and change that, and then automation will help as well. So how can we use information technology? But we're very, very slow at it.
When we, turning to quality and its corollary, in my view, efficiency, the gurus, the Berwicks in the world, they pretty consistently will go public with the notion that 30% minimum of healthcare is absolute waste, and another 20 to 30% is doing stuff of unproven value. You're a CEO who has worked in environments where efficiency was important and in fact mandatory. First, do you buy that? Do you think it's an exaggeration? What did you find in Vancouver Coastal, and where do you think the system is both most efficient and least efficient?
Well, everyone in healthcare would say, if they aren't feeling attacked and criticized, most people would say, we are doing things that are inefficient. And some of that inefficiency just comes from the fact that there are huge queues. So as soon as you build in lineups and wait times and people sitting around or staff standing around waiting, you immediately have inefficiency. So if you say big wait lists in the ERs, wait lists throughout or wait times throughout the hospital, and that could be in the form of ALC or whatever it is, just managing that takes a significant chunk of time. So that's something that in an ideal world you just remove. Now that means that in some cases you may need more of beds or ORs, but most likely you need more services in the community. At least that was the experience we had. People could actually flow through the acute side relatively easily with some process redesign and so forth, if you have the community resources that are needed, beds or home care or home support or physio or family or whatever. So I think that to me is still the single biggest opportunity for us in the healthcare system, is just moving people through the system in a really efficient way. So you're not, as we used to sometimes hear from the ER folks, if they're essentially managing the equivalent of an inpatient hospital unit, that's not a good use of ER skills, for example, or ER capacity. So I think that's certainly one area. There is, compared to the private sector, a lot of scope still to bring in, though, further efficiency improvements, particularly if we focus on quality, because I think that is an area where we can do a lot more and where it doesn't feel like we're just trying to hurry people up, but you're actually saying, let's not make mistakes, let's improve our ability to not have errors, and then you don't have all the recovery and everything else that goes with it.
Another aspect of this is what I would call a divided government view that percolates down to the regions, the relationship between efficiency and volumes. So again, for 20 or 30 years, governments have said, we got to get off the volumes focus. Let's just focus on outcomes. And yet the directives come down, certainly in my province. Yeah, we want you to shorten wait times, and here are your surgical volume targets. And if you don't produce this many hips and this many knees and this many cataracts, we're either going to slap you on the wrist or do some other terrible thing to you. So there's these mixed signals. Do you think governments have given regions the latitude to work this out? Or did you find, as a CEO of a region, that your hands were tied in some ways you would rather than not have been tied?
Well, I think it doesn't matter if you're a health authority CEO or a corporate CEO. I think most CEOs would say they would prefer to have more flexibility and more ability to do things and less restrictions. I think when you're in healthcare, particularly when you're working not only within your own health authority, but you're also working with the ministry, what you see is, in fact, an overall desire to improve health outcomes. And if you had the perfect system so that you could really say, this system is 100% efficient, these are the needs of our population, and that may be a reflection of socioeconomic status or health profile, and here's the 100% efficient cost of delivering that. And if you were a minister or a civil servant, you would say, okay, if we knew that, then we'd be able to go to the public and say, here's the deal. This is what it costs to have a good healthcare system. The reality is we can't do that. So I think sometimes when these targets are imposed, you must do a certain number of hips or knees or patient days or MRIs. It's an attempt to bring some sort of accountability into a system that doesn't have clear accountability if you just say health outcomes. Because if we just say health outcomes, you don't know whether, in fact, a hospital that looks full is full because 20% of the beds are occupied by ALC patients, or whether, in fact, it's full because everyone in that hospital is getting exactly the care they need. And there's no way right now, if you're just looking at global budgets, for a minister or a premier or any other politician to be able to say with some confidence, I know that that hospital is full, but it's filled with patients that need to be there, as opposed to it's filled with patients, but maybe a large number of them shouldn't be. And so I think it's a crude attempt. It is crude, but it's an attempt to at least say, out of all that money that's going to the health authorities or the health districts, at least some of it we know is going to deliver on a certain number of specific targets. It's an interesting area of discussion, though, because there is that constant debate about funding. Should you be funding for individual procedures on a volume basis, or should you be funding on a health outcomes basis? And we tend to
or simply population basis and say, you guys figure it out and we'll measure.
Yes.
We'll agree on the indicators and so on.
Yes.
Which leads us into indicators and information and where Canada sits in the world, which is dismal. You know, when every study of how has health IT, e-health penetrated OECD countries, we don't come across very well. We were last in the 7-country study a couple of years ago, published in Health Affairs. Are you optimistic about this? Do you think that we will get the e-health revolution accomplished? Will there be a pan-Canadian EHR, and will it make a difference?
Well, I think e-health is going to happen, and if we can't make it happen within the public system quickly enough, it's going to be driven by patients and consumers, and we can see that already. So with Microsoft Health Vault and the Google personal health software package, consumers will demand it, and they will be more proficient at software perhaps than we are. So it's going to happen. I think the question is, how is it going to happen? So will it be done in an integrative fashion so that you actually are able to say, this is the ideal, here is, we have all the various components of the public healthcare system integrated with some of the private work that patients want, and we can put together a care plan. We can measure, or not measure, but record what's going on. So you can actually have a tool that's really useful for hospital people, GPs, community workers, and individuals. That's what I worry about, that in fact public demand will get well ahead of our ability as a system to be able to give people what they want. And then there'll be all kinds of other things that pop up.
And then the other side of that coin is, will the system get enough valid, comparable, real-time information to use it for management purposes?
Yes.
And how do you think that's going? I mean, when you were, compare the information environments a little bit from admittedly a simpler but not simple industry like pulp and paper compared to healthcare. Did you find yourself thinking, good God, I don't know anything about what I'm supposed to be running here? Or did you say, you know, some of it's pretty good, some of it I can actually use, and some of it is just a gap?
Well, certainly at if you're looking at management information to help make decisions for, say, a health authority. I mean, it's very, very primitive compared to what you'd expect in the private sector today, and I think most people would agree with that. So there is a huge opportunity. I mean, it is more complex because it's harder to define. You can look at many aspects of private sector products and services, and they're much more clearly defined. So if a patient arrives at an ED, complex patient, it's much harder to say, well, that patient should have X units of care and should stay for X number of days, because we just aren't that precise yet in healthcare. So there is a margin that a judgment call, and also the unpredictability of how the patient is going to respond. But in terms of management information, there is no question that in the healthcare system you go much more on instinct and experience, and relying on people who are out there and saying, okay, well, this is, yeah, we're okay, or we're not so okay. The measurement is very, very problematic. So that's a huge opportunity, but it requires some investment to make it happen. And I think the other thing is it requires people focusing on it and seeing the value of it. And that was one of the big changes, differences I saw between the private sector and the public sector. There's not necessarily a belief that that kind of data will improve decision making. And if you don't believe it's going to be useful, you're not going to spend a lot of money and time on it.
Or there could be the belief that it will, which is why some people are nervous about it. It will change things, right? It changes things on accountability if it's there in front of your face in real time. So it's a real issue. And I mean, again, people are arguing about whether we will be able to aggregate EHR data to be used for analytic and management purposes for, I think, precisely that reason. So given all of this, in your 6 years, what is your sort of most burning frustration? Is it, if I could have got that done, or if I had the authority to do this, I could have made a bigger difference than I did?
Well, for me, the great opportunity that we still haven't been able to really capitalize on is this concept of an integrated system. So looking at it from the patient or the health consumer's point of view, which is, I have a potential healthcare problem, or I just want to stay healthy, and there are a number of services that are going to help me do that, and I don't want to have to sort all that out. And I want to make sure that my specialists, if I need specialists, are talking to each other, and GPs are talking to somebody. So I think all of us in the healthcare system, we're working toward that. If I had to do it again, I would put far more time and attention on moving forward more aggressively in that area. And it's authority. I think it isn't so much authority, it's a huge change management. And you make your day-to-day decisions in terms of, okay, that's needed and that's problematic, and we don't have enough people here, and there isn't a manager there, or whatever, there isn't budget. So time passes, and then you look back after a couple of years and say, well, we had a lot of good intentions, we had a lot of good projects, but we didn't actually get to that tipping point to say the system is now different. So I think there are lots of areas where it's improved, but not to the extent that we need. And if you were a consumer or a patient in BC today relative to 6 or 7 years ago, you might say it's improved a little bit, but you certainly wouldn't feel that it improved to the extent that it should have. I think the other area that we're clearly still not doing enough on in healthcare is the whole aspect, it ties a little bit to what I just said, but it's the whole aspect of demand for healthcare services. So in our health authority, for example, a lot of work had been done to be more efficient. So the whole focus has been on, let's do supply chain, let's do patient flow, let's manage through lean redesign or whatever. So what the experience of Vancouver Coastal was, yes, you can do really good work. You can, in fact, improve the utilization of, say, an ICU or a hospital, and we can see more patients, so a 10% or a 15% improvement in the number of patients you see just by taking all the delays out. As we all know, what happens in healthcare is those beds or those ORs or whatever immediately fill up. And so after a while, you realize, intuitively you've always known it, but you start to see the actual practical reality of if you don't do something about the demand side, and it's a free good, and there's some volume incentives that are built in on the part of some decision makers, and people just want more because there's always seems to be a sense of, well, if you get into a hospital, you're going to feel better or something, which may be changing in today's world. Yeah, that's right. But we're not doing it much on the demand side. And that is to what I said earlier, this is where we need physician leadership, we need people taking more self-responsibility, having more awareness, because what will, I think, eventually tip the system in a direction that would lead the public to conclude it is not workable and not sustainable will be a continued focus on using resources more effectively, continually focusing on the supply side and doing nothing or very little on the demand side, because that picture will not compute, and you don't need to come from the private sector to see that that's not going to work.
And what are you proudest of? What do you think, boy, that was a great experience and we got these things done here?
Well, certainly the work that was done around this whole continuum of care. So taking these 18 or 20 or whatever organizations, bringing them together and having, I think, a very good organization that was focused on an integrated system of healthcare delivery. I think from a personal point of view as well, what I feel very proud of was some of the work that was done in Vancouver Coastal around mental health and addictions, because that's a population that doesn't always get as much focus within the overall healthcare system. And as you would know, in Vancouver itself, there's a very visible need. So there were some really good work that was done to bring new services and a completely different way of looking at harm reduction, treatment, the Burnaby Center, the Crossing Academy as Insight. So that to me was something that I'm really proud of.
We're going to toss it open to you in about 5 or 10 minutes, but I have one more question that I'm only asking this one item because the audience expects it. What do you think of what's going on in Alberta? And what do you think deregionalization? Now we saw PEI, which arguably 140,000 people. I mean, for heaven's sake, it shouldn't even be a province. So you can see why you deregionalize PEI. And I tell my friends who may watch this on the podcast in PEI, I respect what you do there. New Brunswick went from 8 to 2, and now Alberta is deregionalized. Are we seeing the end of an era here? Or do you think this is just a peculiar serendipitous decision, or do you think there is something more permanent afoot in terms of a trend?
Actually, Stephen and I were on a panel last year, about 3 weeks after the Alberta change was announced, and so we had some of this conversation. My feeling, and again, everyone has very different views, is that regionalization was a point in a process of moving towards standardization and consolidation and trying to get the benefits of that. If you think 9 or whatever they had in Alberta before, the current was 29 health authorities, and in BC we had 56 or 70. If that was an improvement over the previous 400 or 500 or 1,000, because you get benefits of more standard approaches and you can consolidate your facilities, then moving to 9 would be even more benefits from consolidation, and then finally moving to 1 would allow you potentially to do a better job on what we talked about earlier, which is one information system, one set of quality parameters that everybody adheres to. The tension, of course, is what you lose in terms of local ability to respond. And my personal view is that within the healthcare system, the local requirements, the need for hospitals and others, or at least the community's desire to link to hospitals, is stronger than the public's desire to see efficiencies that might come from consolidation. And that, to me, I think is where the Alberta experience is going to hit the most challenges. If you look at the private sector, creating larger and larger and larger organizations is absolutely doable and is absolutely workable. So if you can look at McDonald's or something like that, it works as a corporation. It doesn't work necessarily in some countries and some regions where people are not particularly inspired by or attracted to that model. And I think that is going to be the challenge in healthcare, because perhaps people in Paris don't want to eat McDonald's hamburgers, that's no problem. But if it's the only game in town, if that was the only place you could eat, which is the healthcare system, that might create some huge problems. So that I think is going to be the challenge.
Yes, and I suspect that whole issue of what local governance brings in terms of intersectoral responsiveness is an interesting issue too. So let's talk about now. You made the move. Why after 6 years instead of 4 years or 8 years? Was it sort of just opportunity came up, or were you feeling that you had done your time as a regional CEO? Tell us a little bit about your new life and what you're looking forward to about it.
Well, it's always hard to describe when it feels time to make a move. And so I think you're right, it was partly just the opportunity, but I'd been in the health authority for 6.5 years, close to 7 years, and I was told by one of our board members who has spent a lifetime in human resources work, that in fact there's a lot of research that says that CEOs hit their prime at about 7 years and should be gone immediately thereafter. So I'm just a couple of months ahead of doing exactly the right thing. I'm excited about my new my new role, primarily because I think, as we've talked before, there are significant opportunities to create an integrated set of healthcare services. And for individuals, the public system is hugely important, but they also receive care from a variety of other places, could be private delivery or even privately funded. And what people want is just make sure that what I need is available and that it's integrated. So I think coming from the public sector now, I can bring some knowledge and some experience that will allow a company that's essentially private delivery to be much more effective, to create more value, to be able to be more integrated into the actual public delivery system. The shareholders, and Anton referenced Borealis, are really, they're very adamant that they are looking for a long-term strategy, a long-term sustainable strategy, which in today's world, as you know, is somewhat unique and very positive. But they're also very strong supporters of the public healthcare system, and that was something they said right up front, that they want any of their companies or holdings to be part of the public system in a constructive way. So for me, that's positive. I mean, it gives me a chance, I think, to use some of the experiences that I've had.
Last question, because when you're a CEO, you travel a lot, you look at other systems, you read about other examples. Is there a health system or a health subsystem in the world that you would say, you know, if I had to be a patient or a funder, either through a private insurance or a tax funder, they've got it more right than anybody else? What's your ideal?
Well, I don't know enough about some of the other systems to be able to say, as a patient, this is what I'd like. But I did live in Norway, as you know, and I lived in New Zealand. I really liked the Norwegian system. It was automated, it was integrated. You could go to your GP, they would have all your records available. They worked closely with specialists, so you didn't have specialists off. Here's the specialist's prognosis, and that might or might not get to your GP. So what I liked about it was very integrated, it was very automated, and it was much more patient-friendly in the sense that you could go in and here's your test. You could look on the GP's computer screen. This is what the test suggests. Here are the various drugs or pharmaceuticals or whatever, and he's going to select one, and this is why. So it felt much more interactive, and then that led as well, and Norway has a culture around this, to much more, a much greater sense of involvement, and that then ideally leads to a greater sense of self-responsibility. Now, their tax rate is a little bit higher than Canada's too, so I will
Well,
say there's a little trade-off
they kind
there.
of go hand in hand. But the Scandinavians, I mean, they're just genetically more rational than we are, so I don't know that we could ever achieve that. Well, thank you, Ida. And now it's your turn. So I believe there is a roving microphone. Is that true, Anton?
Yes, Stephen, and we do need to use the microphone so that we can capture it on the video. So if you have a question, just even if you want to line up, just let me know and I'll get to you. And in the meantime, Stephen will, I'm sure, fill space with a few anecdotes if necessary. Thank you for that, Stephen, by the way. And Ida, one of the interesting things that we don't often see at our events is there's people all over taking notes. So it's kind of like an academic exercise.
The interesting thing was they didn't take notes when I was the CEO, so I'm not sure what that says.
I'm sure we can learn from that. Dan McCarthy from the BC Medical Association. I thought this was very, very interesting, very fascinating. I relate to an awful lot of what was said. Particularly, I think about the two separate worlds of administration and clinical practice, and I think you see a sense of powerlessness in both groups about the other's world, and this causes a defensiveness and a reactiveness and is totally harmful to the system. I think we need to overcome that. But when you talked about those two worlds, the third world in Canada that I see, of course, is and it's the moose under the table, it's the political needs of the existing government. And this puts a fake timeline that I think would put any private company out of place, because it's the curse of the next election and the curse of the fact that people can be blackmailed, governments can be blackmailed by the most micro episodes. So what I would believe, and I'd like your comment on, is that we need to depoliticize healthcare by handing the decision-making over to commissions or organizations, but relatively neutral ones, which will have the courage to say to the public that you cannot have unlimited services of the demand side, you cannot have unlimited services for limited funds. Because as long as we're living that lie that every political party seems to want to live with, I think it's impossible to be efficient in productivity.
Well, I would absolutely agree, and very, very well said. The interesting thing that we've created in Canada, and in Canada more so than probably any other country that has a public healthcare system, is this separation between the healthcare customer as a consumer and as a payer. And that means it's very easy for people to think about their consumption of healthcare as endless and always available and limitless, and forget at that moment when they're getting their healthcare that they're also a payer. And so then when they're on the paying side, it's all about everything should be available to everyone, but it should cost me almost nothing. And you don't have rational decision-making then, and it means politicians, I think, are in unbelievably difficult situations because, exactly as you say, those few that have stood up and said, well, you can't have everything, Mr. Citizen or Mrs. Citizen, they're penalized. So we have to find a way to remind the public, citizens, that in fact they are healthcare customers, and that means they're a consumer, but they're also a payer, and they have to help make the decisions around value. And if they themselves don't have the information, exactly as you say, that needs to be delegated to someone who does have the information, and they need to stay out of it. But right now, every interest group or lobby group has the ability in today's world, with all the access that people have to media and to public exposure, people have the ability to demand everything. I think within the healthcare system, and certainly when you're in the health authority, and it goes back to what I said earlier, you can see, and certainly physicians would see this all the time, you see the effects of the lobbying and the advocacy that goes on. And sometimes people who desperately need care don't get it, and others who probably could benefit from something, or perhaps not, but the probability of success is quite small, actually have huge resources focused on them. And mental health and addictions is a classic case, but as we talked earlier, prevention is another. And so I would agree with you completely. How we do that is a question, but Dan, it is where I think physician leadership can make a big difference, because if you look at the polls, the surveys that are done, physicians still have more credibility with the public than almost anywhere else, than anyone else. I think nurses are probably neck and neck there. So there is a real opportunity there to help persuade the public. But I agree.
Good morning. My name is Sue Ross. I'd like to take you back to your thoughts about integration of the healthcare system and the issue around prevention and health promotion and building that sector. What I've seen in the last little while in BC is the emergence, I think, of the strength of the NGOs in with the government's support to the BC Healthy Living Alliance, which is, you know, cancer and heart and stroke and diabetes, etc., who have taken on a responsibility to work together and to put together strategies in the community across BC. I think with some very positive results, and the organizations have embraced that role. So I'd like you to just comment on whether or not you see this as an emerging sector within healthcare as part of the integrated system.
I would say yes, and I think it comes back to what I said earlier as well. The public is going to demand certain things, and if they feel that as an individual they're not necessarily getting what they want, or there isn't adequate focus on their particular need, then they will start to come together. That can be very constructive and productive if you have responsible organizations. It can be less so if you have organizations, as Dan said, or individuals that are perhaps not quite so responsible. I think the challenge and the opportunity for healthcare is how to integrate. I'm going to use that word integrate again, but we have to work together. Healthcare is not about medical practitioners or clinical care. Healthcare is about having a healthy population and a healthy community. And if we think that we have enough money to actually have healthcare professionals provide all the healthcare that's needed in our communities, we're kidding ourselves. There'll never be enough tax dollars. So volunteers and peers, as I said earlier, that has to be part of it. So we have to find a way within the actual public healthcare system to not only invite people in, but to find ways to have the time and the effort and the expertise that they bring put to very good use to improve overall outcomes.
Hi, Ida. I'm Heather Wright. I'm a Vancouver community manager. And I think reading in the Longwoods newsletter, I believe one of the big hospital systems in the States said what they've gotten on a lot of investment for their money was actually partnering with patients and caregivers. And I think that is a way to actually change the system, because currently on a daily basis, I have to tell clients and family members that there is a limit to the service that they have, that there are these are the options that they can have, and this is what can be provided. So I think if we partner with them, which might be easier than partnering with the physicians at this moment, that we'll be able to move forward in creating a system that actually meets their needs. And we talk now more about what is the client's journey through illness or with a disease process or with their health need. And if we can match our systems to that, then I think we'll have a better world.
No, I would absolutely agree with you. If we focused all the work that we did on, this is what the view is like from the perspective of a patient, and this is what they need, and the public system can't give everything, but somebody can. Now, how do we make sure that the overall service for the patient is optimal? You're absolutely right. We would be able to move more in that direction. So I think it will come because patients will demand it. It's just we'd like to be leading that, not responding and reacting.
Well, it's a tradition at Breakfast with the Chiefs that you're out of here in exactly 1 hour, so we got to cut it off. I appreciate the question. Stephen or Ida, do you have a final comment? You want to wrap up? You want to? He's giving you the chair, Ida.
Oh, well, you're going to let me say something? And
Did you feel you were unable to express yourself completely, Ida? I think take the opportunity now.
no, I was just going to say, again, to follow up on one of Stephen's questions around public versus private. I still think that the environment in healthcare in the public sector or the private sector, as far as that goes, is phenomenal. You will not find a private sector, profit-oriented company outside of healthcare, at least that's been my experience, that has the same sense of we're giving back, we're doing valuable work compared to what you'd see in healthcare. So the aspect that I miss the most, and I still have it in LifeLabs, but even there it's a little bit less perhaps, but compared to, say, a real private sector, a forestry company or something, it's this sense of we're doing really valuable, important, meaningful work, and that happens every single day. And so that's something I think for all of you who are in the healthcare sector to really cherish, because it makes a huge, huge difference. And not everybody can say that.
Let me wrap up by saying that we do appreciate the very generous support from both CGI, and Alistair is here somewhere, and Accenture. These are two companies that support our activities across the year, and we couldn't do it without them. And courtesy of them and your attendance, our two presenters, we make a small contribution to a charity of their choice, and we're pleased to do that. And maybe you could show your appreciation for our panelists today. Thank you for coming to Breakfast with the Chiefs.